Hello, everyone. Thanks so much for joining us. We are going to get started in about 1 or 2 minutes. Okay, let's get started. Thanks so much, everyone, for joining us today. We are really excited to be here to talk about compelling strategies for managing Medicare Advantage patients in your practice. I have the pleasure of being joined by Robert Trainer, who's an audiologist and also a practice consultant with Pivot Hearing, as well as Will Dials, who's a hearing instrument specialist, as well as a practice consultant for Pivot Hearing. Robert's going to take you through the presentation that he delivered on this topic at AAA. So we've been thrilled just to be able to make this available to more people who weren't able to be at AAA in person. And then Will is actually going to take you through a new way to determine whether participating with third parties makes sense for your practice. So we have a great agenda for you this morning, and just a little bit of housekeeping. If you have questions during the presentation, you can go ahead and drop those in the Q&A box that you should see at the bottom of your Zoom interface, and we're going to leave time at the end to answer those. So with that, I'm going to turn it over to Robert.
Thanks, Chelsea. So I'm amazed at how many people have signed up for this particular talk, and I know it's because Will is going to do something that's really unique and interesting. And anyway, and again, I'm really excited to be working with Pivot and Will and his colleagues and Chelsea as well. Just because I think in some respects smaller is better, and so let's kind of get into this strategies for managed care. I'm also more excited about this presentation than I even was at AAA because of the interesting things that Will's going to talk about when we finish my side as to how you actually can make decisions in your practice as to whether to use managed care, whether not to use managed care, and that kind of thing. So one of the first things that come up here is where did this stuff come from? And then we want to look at why are we in the situation where we have to think about the managed care and its impact on our practice. The other thing is the kind of impact that this situation is having on practices. And anybody who's sat in the seat of a practice owner knows that this is an important situation that needs to be managed. So we might call this managing the managed care in your practice. It would be another title for this talk. But then we'll talk about what we can do about it. Now, I'm going to talk a little bit about what could be done. And then Will's going to talk a little bit more about how you make that decision for your particular situation. You know, these managed care things or third-party administrative programs have been around for a while. And I remember when we first started seeing some of these programs, I always thought it was a little mysterious, just because, okay, who's doing this and what's happening, and why do you think you have insurance when you really don't have much of a benefit, and why did you consult your fax machine when it came time to get a hearing aid and that type of thing? So I always thought these were pretty mysterious issues, and of course, managed care has a big definition, and that's listed here. But it really is care that's delivered by a specific network of providers, people that have been chosen by the third-party administrators or the insurance company to provide care. And when you accept that, of course, as we all know, when you sign on the dotted line, you're accepting that to be, you're accepting the idea that you're going to work through their particular case management process. So that means that you've signed on to their program. Now, these are all, I always thought this was a little weird. Of course, you had the third party administrator, and then you had the insurance company, which sometimes is the same thing and sometimes not. And the policyholders, these are our patients. And then there's us over here on the side. So it's kind of a three-pronged idea of what's happening, and there are benefits and limitations for all of these participants in these managed care programs. Well, where did all this stuff come from? Well, managed care in the beginning kind of began around the 1890s or so, and flourished in the 1930s during the Great Depression. And we can differ as to how many Great Depressions we've had since the Great Depression, but really this managed care program was designed to be more of an altruistic kind of a situation where we were trying to care for people who couldn't care for themselves or didn't have the cash to take care of themselves. And so in the 30s, there were health cooperatives that came about. And these were occupations. All the plumbers or all the butchers or all the farms or whatever would have a program for the individuals that were part of that occupation. Companies, maybe Ford or JP Morgan Bank or whatever, the various companies would have a program for their participants. And unions, the plumbers union or the horseshoeing union or whoever it was would then have a program for their individuals. And of course, the company or the occupation or the union would pay for the health care, or the consumer would pay a small fee each month for their health care. And so they would pay a certain premium, so to speak, for whatever they needed in the healthcare realm. So that's kind of where all this stuff started. And some of the pioneers in these programs were the program, the Health Plan of New York, which turned into the Group Plan and later on. But this thing started in the late 1930s and now has turned into a program called Emblem Health, which is the big one in that part of the world. And the health insurance was then born about 1937, and as a system that would protect the everyday individual from some sort of financial misfortune or whatever accident or illness that they may have incurred. And then another big one in the Minneapolis area started around 1937, and it was started really by a credit manager and a guy who was a kind of a cowboy, but also a postal worker and a lawyer and some sort of a co-op manager. And since managed care was illegal in Minnesota in the 30s, they finally changed the law in 1957 and began then full-blown as a managed care operation. And of course, there's always the Kaiser Permanente, and this was Henry J. Kaiser, the guy who built the airplanes and the vehicles and the ships and all the kinds of things that went into World War II. And he was concerned because a lot of people in the shipyards and steel workers and some of these places didn't really have any way to pay for health care when they needed it. And of course, at that time, World War II, we needed to have as many people working all day, every day as possible to put out the kinds of equipment that was necessary for the military operation. Later, Henry Kaiser started Kaiser Permanente. 1945 was his big year in beginning this particular program. But about 73 was when the big changes hit this particular program. The 1973, so you think about that, let's see, that's probably during some interesting times in the US when we were all going through a lot of political turmoil, but bigger than that was the Health Maintenance Organization Act of 1973. And what was that? Well, it was designed to reduce healthcare costs because, boy, they were getting really high. And if they thought they were high then, boy, I'd like to go back to 1973 and maybe have those healthcare costs. But it was designed to reduce the cost of healthcare overall. So the act said that if you had 25 employees or more, you were required to have an HMO, or a health maintenance organization, option for your workers. And what this really does is this begins the large for-profit healthcare organizations. Now, here in our part of the world in Colorado, we have great big buildings with UC Health on the outside. And in your area, you may have Emblem Health or Health Partners or Kaiser Permanente, or big letters on great big buildings. These are the kind of umbrella organizations for the actual healthcare providers. And so this act kind of began a lot of that interaction with these large for-profit healthcare organizations. Now, today, managed care is delivered to by groups to. I'm going to move this up just a little bit so I can see what I'm saying here. Healthcare delivery systems do things like when they're doing managed care. They're there to manage the costs, but they also want to manage the utilization, how much the system is actually used. And then also they want to keep the quality at a high level so that everyone receives very good health care. And these days there are many types of programs that are out there in the realm of managed care. Now, how does it cut costs, though? What does managed care do that allows them to provide the services for less cost? Well, the way they do that is have restrictions on the authorized providers. So they don't allow everyone to be in their network. And they also restrict the products and the levels of the products that are in the network, as well as the services that they will actually provide and pay for. And then they may also cut the costs by having a financial contribution by the policyholder or our patient that has these programs. They'll have a financial contribution from them to the program. Now, we're all somewhat familiar with Medicare. There's the Part A for the hospitals, and the Part B that's for the outpatient stuff, and the Part D for the drugs. But the part that's of interest for us today is Part C, which is the third-party administrators or the managed care programs. And this is often just kind of referred to as Medicare Advantage. So let's kind of look at this a little bit. And one of the things that I remember, and for sure, we saw some of this in the 90s, but not near what we saw. By 2005, 13% of Medicare recipients were actually enrolled in managed care. And so that's like 5.6 million individuals at that time. And every once in a while, somebody would come in and they'd say, I think I have insurance. And so we'd check it out and do those kinds of things. But in 2005, it was there, but not really there as it is today. By 2010, it had doubled to almost doubled at 24%, where we had 11.1 million. And then as we moved further, 5 years later, we had 16.8 million, or 31% of the Medicare recipients were actually enrolled in managed care. And now that's a third. This is when we started seeing people, not everyone that walked in the door, but maybe 2-3 a week, 3-4 a week, something like that. And as we moved into 2020, it's you run into one of these people most every day, and almost 40% of the individuals by 2020 were enrolled in Medicare Advantage programs. Now, the thing that I found to be of interest is that by 2021, here we are at 44%. So now you know why you're seeing many, many more of these individuals. It's almost 50% of the individuals that are enrolled in Medicare that are involved in managed care or Medicare Advantage programs. So, and down here, you on the bottom, you can see that 2020 we had 62 million individuals enrolled in Medicare, and with 40% of those looking at managed care, you can see why you're seeing more. 2021, we have 64 million, and remember, we have all these people that are turning 65 every single day. So, so this is going to do nothing more than become a greater percentage of the Medicare population. So we've seen a 300% increase in 16 years. And likely in your practice, you've seen a 300% increase in the number of people who say, you know, I think I have insurance for this. And then that clicks for a certain response from any of us that are seeing the patient at that time. You can see that programs in 2010, there were only like 2,350 or so programs that were out there for Advantage care. Now we've got well over 1,000 more at 3,834 by 2022. And this is from the Kaiser Foundation. So this is a huge increase in the numbers of these programs that are out there. And in fact, here is the 2020 breakdown for the various states. And those of you who are from the red states see that over 40% or more have the Medicare Advantage programs. And if you're lucky enough to be from Montana, North Dakota, Nebraska and Kansas, and some of these kind of golden colored states, you only have 11 to 20%. But if you're out in California, Texas, or the Southeast, maybe up in the Rust Belt or in the Northeast, you're going to see lots and lots of individuals that have this Medicare Advantage program. So, so this is a map of the places that are impacted the very most and some that are impacted the very least. I would also say that if 11 to 20% of your patients are in the Medicare Advantage programs, you still have a problem that needs to be addressed. Now, this comes from Aaron Bailey, who's done a hearing industry map for quite a long time. We've done a number of these over the years. But you can see all the circles on here are in the industry. You know, WS Audiology has some managed care programs. Starkey has some. Amplifon, of course, and Demont has some. So not all the manufacturers are staying out of this program. They all see it as something that's going to grow and grow significantly over time. And of course, none of us would have a problem with the VA and how they handle their program. That's not necessarily managed care. We wouldn't see those patients anyway, simply because that is the hearing aid benefit and the audiology benefit and so on. That's part of the benefit from their military service. And of course, then the ones we're concerned about are the CMS or the Medicare recipients that are well over 45% now. And of course, these are some of the major players, you know, Humana, Blue Cross, Aetna, United Healthcare. We could probably add Kaiser Permanente and Emblem and all these other ones in there as well. But I think one of the things that's a disturbing kind of a note for all of us is the health innovation program that's offered by United Healthcare, where they've decided to manufacture the amplification products, and not necessarily at the same quality level that all of us would like to see our patients working with, and not necessarily with the kind of follow-up that is absolutely essential. Sometimes when you see those kinds of programs and how satisfied patients are, you can see why sometimes these direct to consumer programs are having a little bit of a they're beginning to rise a little bit, simply because the 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 managed care programs are not what they should be. So now, why do we have so many of these things? Well, there's a whole lot of high pressure sales tactics. I mean, you think used car people are bad. The TV ads by all these old celebrities are really they're not comical. They get annoying for me, and I'm sure for you, but also I think for consumers. And here's some of the ones that I'm sure that you haven't missed yet. First, the high pressure sales tactics are used by some of these people who were on TV back in the 60s almost, because that's the kind of patients that we were all seeing, 60s and early 70s. So the first one that comes to mind is Bill Shatner, who actually sits on our board at the American Tinnitus Association as an honorary member, because he has a lot of tinnitus, and that's part of it. I don't know if it was from being beamed up all the time on the Starship Enterprise or what it was from, but anyway, Bill Shatner's on there talking about how great Medicare Advantage is and all the things you get. Another one is Jimmy Walker from Good Times back in the early 70s, who was playing a character called Dynamite at the time, and he talks about how much more benefit you're going to get from managed care than just from traditional Medicare alone. And then, of course, who could forget Joe Namath, who's on TV all the time. In fact, I'm going to pick on Joe just a little bit here because I want to make some points about high pressure sales. And some of you may not even were born when Joe did this. Others of us who have been around a while remember the day. I was actually a frat kid in about a freshman or sophomore year, and Joe Namath guarantees a Super Bowl victory for the low-life New York Jets, which was just a kind of a pretty low-level team at the time, and so this is what people remember. They remember Joe for his guarantee, but they also remember Joe for he was called Hollywood Joe at one time, and you can see that when he wasn't playing, he'd sit on the bench with a big fur coat and look cool, and that was all part of his interaction with the world at the time. And guess what? Then he also went to sell us different products. You know, here's selling at Hamilton Beach things, and I remember this hot lather machine that everybody seemed to think was pretty cool at the time. And I don't know if it was because of Joe or if it was just kind of a fun thing to play around with. Then hairspray, skin moisturizer, all kinds of things. And instead of Hollywood Joe, when he started running around New York, they called him Broadway Joe. Now, here we have a guy who is not quite the suave and debonair individual that he was in the 60s and 70s. But he's telling us that we could have dental plans and vision plans and hearing plans and all prescription drugs and all these different things. And he's here just to tell you, because if you're on Medicare, this is important information. Now, for me, this reminds me of Hollywood Joe saying, "Do I have a deal for you?" So these are, again, some of the high pressure tactics that are used to actually sell Medicare Advantage. These celebrities are cool, and they have been cool, and they now are trying to sell you stuff that may or may not be the best for you. And when they do this, they say, yes, you're going to get eye exams and glasses and telehealth and dental benefits, fitness benefits, over-the-counter benefits, and I'm not sure if that will apply to over-the-counter hearing aids or not, but that's a possibility. Some sort of meal benefits and transportation here and there. Again, they'll even pay for bathroom handles and all these other things that go in. Maybe even that walk-in bathroom tub kind of a thing that everybody sees on certain news programs. In-home support. But the big one that people hear is hearing aids. 72% of the 3,800 or so programs offer some sort of hearing aid benefit. And in fact, the recent market track survey said that they polled prospective individuals and asked them if having health insurance or that covered some or more of the cost for amplification, what would that do? Would that motivate you to purchase sooner? And 48% of them said yes. So that means that people are looking for some sort of an insurance program or someone to kind of fund what they think is their right at this point in time in their life. Well, as practitioners, we have some things that could be pros, or we have some things that could be cons relative to accepting this managed care increase that we've seen so much of over the last 5, 6, 7 years. And one of the benefits that we can get from it is, it costs $350 to $450 just to get an individual in the front door anymore. And that depends on where you live and what kind of a practice you have and so on. But it costs a lot just to get a private pay patient in the front door. With managed care or the Medicare Advantage programs, the patient will call up and they'll say, "Oh, go see Chuck's hearing aids over here," or go see Kenwood Hearing, and they'll take care of you. And so you get the patients with no upfront costs in terms of getting that person in the front door. Now, that doesn't say anything about the cost that it's going to cost you whenever you work with that patient, but at least there's no new patients with zero marketing costs. And you may be able to sell these patients later on. You may talk them into the fact that your practice is the way you do business is better than the way the insurance programs do business. A lot of us count on that transition to grow the practice and keep ourselves going well with keeping our schedules full. And it makes us feel good too, because we're offering affordable treatment options for our patients. And of course, any of us that are working with the hearing impaired and in hearing healthcare do have a heart as much as we have a need to make a living. And so this makes us feel pretty good. And there are probably some other kinds of things that could go into this discussion on the pro side. But the con side is reduced or no margins on products. Now, that is an issue, because when we do products to private pay patients, there's always some sort of a margin there, as well as some of the other things that we do. In fact, it's been found that it takes 3 third-party administrator patients or 3 managed care individuals to equal the margin that you'll obtain with 1 private pay patient. So you got to do 3 people for every one to make what you would make with 1 individual. Excuse me. So the other thing it does is it compromises long-term relationships with our patients, because one of the things we always shoot for is a long-term relationship. We don't want to just sell somebody something and see them and then never see them again. We want to get to know them. We want to get to know their issue. We want to get to know their family. We want to get to know everything about the individual that we should know, so we can do a better job with them over the long period of time. So we're looking for long-term relationships, not somebody who's just looking for a deal and then we're gonna work with them and then we never see them again. So this does compromise long-term relationships with patients, and none of us are looking for short-term. We want long-term people that we can get to know. And when I left my practice a couple of years ago, I found I missed all my friends that were patients, and because I'd been in the same community for 46 years, it was quite a transition to leave clinic and leave all these long-term relationships that we'd spent years developing. And if somebody comes in and they've been a long time private pay patient, and somebody comes in and they're just a managed care kind of a patient, you want to make sure that that private pay patient that's your friend that you've known for a long time is taken care of. So sometimes there's optimal patient care that goes along, and some suboptimal experience and outcomes that go along with the managed care patients compared to what you offer for your private pay. And with all due respect to all of my colleagues that want to have the same for the insurance people and the same for the private pay patients, if you do that, you're going to be compromising your private pay patients for your managed care patients. And it is not a good idea to do that, because it will then compromise your private pay patient load as well. So anyway, so what do we do about this? How are we going to approach this particular issue? Well, more than half of the Medicare beneficiaries they report that they don't review or compare their coverage annually. I mean, they don't look at it. They just, oh, I got insurance for this. They don't even think about what kind of insurance or how much insurance or whatever. And in fact, this is a thing that Will found from the Kaiser Family Foundation that shows statistics on this issue. Now, on the left side there, you see that 46 or 43% of these individuals, check what their benefits are at least once a year. That's a hardcore group that really knows exactly what their benefits are and where they're going to go and what they can do about different things. But look at the other side. Almost 25% say, I never check that stuff. Another 22% say, well, I only check that kind of whenever I think I might need to, which is rarely. Another might say, well, once every few years, whether I need to or not, so to speak. And then there's the 3% that only looked at it when they first signed up, and that's it. So what does that do? That leaves us 57% of Medicare Advantage recipients that don't review or compare their coverage options annually. So there's a whole lot of people out there that are Medicare Advantage individuals that don't actually know what kind of a benefit they have. So when we look at a continuum, how are we going to handle these people? Well, one side says there's a group that always reviews their insurance before it's provided. That's at 43% we talked about a moment ago. Then there's the group who never looks at anything. And then there's the group who kind of looks at things before their service is provided. And our contention here at Pivot is that these are your private practice, private pay patient pool. This 57% of those who never check, rarely check, or sometimes check, once in a great while check. So that's the patient pool that we want to go after with as possible managed care patients, because these are the individuals who might just switch over to a program that we may have designed for our particular practice. Now, there's a way to look at this in terms of how we're going to approach this 57%. And some of them we're going to say, well, we're going to just only take third-party administrator patients or managed care patients. Another side would say, we're going to just totally divest from these third-party administrators and all these Medicare Advantage individuals. And then there's a group who may need to kind of look at kind of a hybrid program where you take some managed care individuals and some private pay patients. And one of the cool things about our discussion today is that when I'm done here this morning, Will Dials is going to come in and I think be able to show you how to make the decision of only TPAs, no TPAs, or hybrid TPA patients. So now, if we want to make some strategic responses, how would we, if we're trying to get rid of this program, first of all, it's going to be difficult to get rid of a program that has grown 300% in the last 16 years. But one of the methods that could be used is to band together as groups, maybe HIS and AAA and ASHA and everybody else all gets together, and we get tough on these third parties. If we get tough enough, they may go away. This is a program that's totally dead on arrival. First of all, it's difficult to get people to agree at the state or national level on almost anything, and there's huge diversity on various components of practice and how we interact with Medicare and Medicare Advantage and all these different things. So it'd be pretty tough to get that done. And further, if we don't like it, these patients will then go to manufacturers' clinics who take everything and not even think about it. Individual practices can actually divest themselves of the third party or the managed care groups with using strong business fundamentals, as you're going to see here in a little while with the dashboard that has been designed for making these decisions. And hopefully, by looking at the strong business fundamentals, as well as coming up with some compelling alternatives to offer patients, that's another key that will facilitate the capability to be able to look at these patients realistically, maybe even turn them to your program for your practice rather than the insurance program that they feel they have. Now, another way you could do it is to disrupt the whole system through legal and regulatory channels. And of course, this is another dead on arrival kind of a thing, because practices are the ultimate underdog in this whole battle. I mean, they just see a practice as those rich hearing aid people are out there just trying to get richer. And so legal ideas, and the more ideal as a forensic audiologist with a lot of things, you don't want to get part of the legal system unless you really have a good battle, and we are the ultimate underdog in this battle. So it's not a good idea to get in with these people on their turf, because this is their turf. They might not know a whole lot about hearing care, but they sure know a lot about legal and regulatory issues. So it's not a viable strategy for all of us to look at to make this system go away. And then, of course, I love this slide. This is one of Will's slides of the horse with the blinders on. And what this does is it allows us to look at maybe we're going to not exactly do anything at this point. Now, in the near term, staying out of the Medicare Advantage programs, the insurance programs, the third-party administrative programs, in the near term, that's probably fine. But as 2022 turns to 2023, 4, and 5, those numbers that we talked about earlier, instead of 300%, it's going to be 500%, 700%. So we have to kind of figure out some sort of a strategy. But right now, you may be okay while you're thinking about what to do. Private pay patients, however, will be declining, and we have seen that over the last number of years. In fact, now this data is a bit old, but this comes from Greg Fraser's talk in talk as well, but comes from his article in Audiology Today in 2017. And at that time, we independent clinics, such as independent dispensers and independent audiology clinics, were at about 39%. And this is what was estimated in 2020. By 2020, now this doesn't have any COVID factors in here at all, but we estimated that we'd be down by 9%. My guess is we're probably down by more than that now, just simply because of some of the COVID issues, plus other issues that have come up since that time. So the number of private pay patients is beginning to dwindle, and it is in the favor of some of the Medicare Advantage programs. Now, another thing we can do is we can just take the poker chips and go all the way in, and but consider when you do that you are at the mercy of all of these programs. You are at their mercy for a lot of things. The benefit that you get, however, is you have zero marketing costs with these individuals because they're going to send you their patients. But the problem is, not only does it provide a undiversified referral source, but while you're providing these affordable treatment options for all of your patients, you're also reducing the value of your practice. Now, if you're just 3-4 years into practice, that's one thing. But let's say you've got a practice that you've been doing for 25 to 46 years, as I did. You don't want to get too involved with these people because that reduces the overall value that you can sell your practice for if you're just doing primarily managed care. So you have also no control over the fees that you generate because you are totally at the mercy of these third-party programs. And of course, you also have to provide the services. You've agreed to provide the services that they suggest or that they mandate for their managed care patients. You have to provide those whether you get paid for them or not. And so again, totally at the mercy of these individuals. Now, another strategy that is thought to be of some benefit, it worked for a while because I used this for a while in my clinic. So you just put everything on sale. Excuse me, if somebody has insurance, then you might want to just kind of, historically, we've dropped the price by reducing the technology level. And that worked for quite a while, but the manufacturer clinics and the Costco clinics and these other places, they all got wind of that. And today it's not a very viable strategy because premium technology is available from the big box stores, from third-party programs, from manufacturer-owned programs. And you and I may disagree about the level of premium technology that you get in these places. However, the patients will see that as, well, I can get a premium here, I can get a premium there, I can get a premium somewhere else. And we don't necessarily need to consider that. So, so now Dan Enrollee is a professor at Duke University, and he says the biggest thing is when you go from the pain in paying is one of his issues, and the biggest increase in the pain of paying is when you switch from paying nothing, like in managed care, to paying something, or paying less with managed care than paying more with something. Now, one of the ways you can kind of modify that is by maybe looking at some unbundled kinds of programs, but you have to be careful about how you unbundle. You can't just unbundle and then sell somebody a package of wax cards for $20 or sell them a receiver for $500. You can't nickel and dime each and every patient for every single thing. You need to sell them package programs that allow them to get a lot for what they're paying for their package program. And so that's a way to unbundle. But if you do unbundle, you just want to be very careful about how you do that and make sure that it's not a nickel and dime kind of thing for each and every patient that you see. So the whole deal is staying in control. And by staying in control, that's what we want to be seen as, is a steady state kind of a movement toward hearing care. And to do that, you have to set up some fortifications. And by fortification, we mean do the things that we do the very best and continue to do those things. So, for example, you want the best practice patient experience possible for each and every patient. That's your reputation. That's how you build your practice, by being the best place, offering the best services available. These are things like Pivot has something we call the hearing aid test drive, real ear verification. Maybe you do quick SIN. If you're taking impressions, don't do impressions. Do scans now. These are all best practice patient experiences that put your practice just a cut above some of the other places in the area. And then, but this is, you can't do best practice patient experiences without having some sort of patient flow. And of course, the costs in obtaining patients are high, but what we want to do is to take our existing database, and we can still market to those individuals as we always have. And but the new patients that come in, we can market to them one way, but we want to keep them out of the managed care system. And the way we do that is by looking at alternative programs. Maybe we have a premium program and we have an advanced program, and we list on a sheet the technology that's available and how you can upgrade if you choose. Maybe we look at the professional services and warranty things that are involved, or the supplies that we will include with the device. So a program, you can call this one's called Access Hearing Program Options. You can call it the Tulsa, Oklahoma program, or you could call it the Premium Hearing Care Program, or you can call it whatever you choose. But the idea is to have some different programs and have all the things that are included in those programs on a sheet that you can interact and discuss with your patients. And in fact, you can even have a access hearing program comparison, where you have maybe under other programs, you have one or two of the programs that are involved in your area, plus then you have an alternative program that offers significantly more. It might be a moderate price increase above that, and that's often a compelling argument. That's an alternative for our managed care patients. And so you can take your access hearing care options and place them with the access hearing care comparison, and I know that my friends at Pivot will help you set this up with all your logos and everything on the name you want for your program, and how you go about choosing to present this, so you feel comfortable in how you do it. Some people feel comfortable in talking about programs and costs and things, and others don't feel so comfortable. But these are things that can help you move people from their managed care program into your particular program that's designed around your area and your practice. And so you want to fortify against all the competitive threats. And one of the ways you can do that is by some programs that are offered by some of the Pivot practice consultants. And so by looking at the hearing aid test drive and some of the counseling tools, various things that not necessarily to replace your counseling tools, because if you're like me, that my stuff was best, but to augment that and add some things maybe that weren't quite there, and then maybe some sort of a physician referral program. In fact, when somebody started a new practice in my city, the first thing they did was go after all my referral sources, and so you want to put some barriers around your referral sources, and the practice consultants can kind of help you in that regard by facilitating new patient acquisition programs. And of course, you don't want to forget your database, existing patient engagement. And these are things like competitive pricing, competitive newsletters, and a third party kind of a fighting program. This is a lot where you're going to be involved with taking your current database and talking them into your program rather than a managed care program. And then over here is where you really can, this is the decision maker. This is where you, and now many of the dispensers often come from a business orientation, but having taught practice management and wrote a practice management textbook, I can tell you that many of my audiology colleagues learn, well, like I did, I got out my wallet and learned how to manage my practice. And later went on to get some business orientation. But there are people these days who can help you look at the market. They can provide recruiting and personnel management. They can help you with leasing programs, which are gaining in popularity everywhere. Business planning and some of the other kinds of things that are necessary to keep your practice on the straight and narrow and moving forward all the time. And when you do these things, these are the guys out here who are just that crowd, and they're the individuals that aren't really doing anything about the 300% increase in managed care. They're not doing anything about looking at the market, looking at their practice. They're not engaging their existing database, and they're not actively recruiting new patients in a way that is beneficial to their practice. But when you have all that information, it pulls you out of that crowd and makes you a much more successful individual. And with that concludes my remarks about managed care and kind of where it came from, a little bit about why we really care and why we're having this kind of a webinar in the first place. And now I'm more than happy to answer some questions, but you're really in for the treat because we're going to show you, my good friend Will Dials is going to show you how to actually make the decision whether you want to go all in or whether you want to go all out or whether you want to do a hybrid kind of a program. So thank you very much for your attention, and we'll I hope you listen carefully to what Will has to say about managing your clinic and your managed care program.
Great, thanks, Bob. I'm going to go ahead and share my screen here, which I think I'll need you to stop sharing yours first, if you don't mind.
Well, I guess I better stop sharing. All right, and there we go.
All right, thanks, Bob. All right, so yeah, I'm going to go ahead and pull up my screen here, which hopefully you're all seeing it here. And what you're looking at here is our new interactive KPI dashboard tool that we've created. And we could spend an hour plus going through this in detail, but what it is at a high level is a KPI dashboard that integrates seamlessly with the major OMSs in this in our space, Counselor, Blueprint, Cycle, and TIMS. And it pulls in data from your OMS, and in a few other sections pulls in some external data sources and allows us to really leverage that data to make decisions for our practice. And I can't think of a better use case for that than trying to come up with a strategy around managed care, what kind of impact it's having in your practice, in your market, and what you might want to do about it. So I'm going to just briefly, I'm going to go through a couple little things here. And this is a demo file. This is a fictional practice that we've placed in the Tulsa, Oklahoma area. So if anybody hears from Tulsa, this is completely made up data, but it was just a nice market to show off what this tool can do. Okay, so in this section of the tool here, it's a market analysis tool. It combines data from the US Census, various industry sources, which provide, publicly available things like the number of units sold annually in the country. We look at market track data to estimate hearing aid adoption numbers by age group. So what that gives us the ability to do is when we pick any given zip code here in the country, and in this case, I'm going to pick the one in Broken Arrow, Oklahoma, 74012. That's where this fictional office is headquartered. And let's set a 20-mile radius here. So what this tool is filtering for is all zip codes within 20 miles of the home zip code here. So we've got important things like demographics, and we get all sorts of great demographics from the census. So we can look at where the population is over the age of 65, which is generally where people are more in need of care of the services we provide. Household income also plays a role as well. And what we're able to do is in any given market, estimate the number of hearing aid users, the private pay units sold annually, third-party units annually, and then what percentage of the overall market is third-party. And it varies a lot depending on the market. And then what's really neat is that we can even bring in the OMS data to see how not only what the market looks like, but how you're doing in that market. So we can see how many private pay hearing aids you sell annually to these patients in these zip codes. So we can therefore look at your private pay market share. We can see of these estimated hearing aid users, how many of them are active hearing aid patients in your clinic. And by doing that math, we can calculate a penetration rate. So we've looked at this at a bunch of different markets across the US and helped practices make decisions as to whether to participate or not participate, or maybe if you currently are participating and you might want to think about divesting. So the things I would look at was, let's just see how big of the market, how much of the market is third party. Is it too big of a chunk that we just can't ignore it, or is it relatively small? And then what kind of private pay market share do we have? That's obviously really important. And then just this overall penetration rate, I think, is probably the most important thing to look at and keep in mind when you're making these decisions. So, and just from our experience, if your market penetration is above 20%, that's pretty good. And that would mean that you might want to consider divesting, or at least that divesting is something that needs to be thought about and considered. And if you're under 20%, every market is different. Every business owner has got a different goal for their practice. So there's no one size fits all, but that's kind of just a little threshold that we've seen that makes sense in terms of when to consider going one way or another. The other thing I would look at in this instance would be to come in here and see. So for this business here, this is a part of the report that shows where the business is coming from, the sales, the patients, things like that. So we can look at the referral source level, new versus existing patients. But what's relevant to this conversation today is this private pay versus third party. So in the case of this practice, third party makes up a kind of a tiny percentage of the overall sales. 22 patients have gone this year through third party, almost 500 private pay. So the divestment decision, if it were to be made, would not have a huge impact on the overall sales. And just to look at it in a little bit more broad time period, longer time period, last year, all of last year, it was under 4%. And over the last 5 years, under 4% as well. So not a huge percentage of this practice's overall business is currently coming from the third party channel. The final thing I would look at, I would come in here and look at this. This is a section of the report where we measure all sorts of things, but one thing that's relevant to this topic, I think, is the schedule utilization rate. So we can see how full the schedules are. And in this case, the schedule, at least for the next week, is almost 100% full, which is generally the case in this practice. So if you don't have big gaps on your schedule, then it's easier to make that divestment decision, because if that's where one thing where third party can really come in. If you have holes on your schedule, they can generally come in and help fill that. But if your schedule's full, you got good penetration rate, third party is not a huge chunk of your business, then I think that I would lean towards strongly considering divesting for this particular practice. But again, every situation is different, every market's different. So I'd be happy to talk to anybody on a one-on-one basis and go through this in more detail. So
great.
And with
Thanks,
that,
Will.
yep.
If you want
Chelsea
to
will
stop
take it from
sharing,
here.
I know we are
Sure.
almost at time here, so we'll wrap this up really quickly. Okay, let's see if I can get this. Can you guys see my screen okay now?
Looks good.
Okay, awesome. Okay, well, thanks, Will, and thanks, Bob. We're going to jump into Q&A here in a second. I know some people are probably going to have to drop off in a minute, and that's totally fine. Like Will said, we're available at any time. Pivothearing.com. It's really easy to call us or schedule an appointment with us. But I did just want to share our philosophy here at Pivot Hearing, which is that when private practices put patient care and experience at the center of what they do and build fortified business models around that, they will succeed no matter what the challenges that arise. So I know some of that data that Bob shared in the beginning can be a little scary, but we do really believe that private practices who do the right thing by the patient and with the way that they run their businesses will continue to be successful. Start with patient care, business results will follow. I also want to read our mission statement, which is that Pivot Hearing stands with private practices because we believe they provide the best patient care, and it is our vision to successfully fortify those practices to thrive in their local markets. The key to your success now and in the future is to develop and communicate compelling reasons why patients should choose your practice over the other competitive alternatives, whether that be your competitor down the street or Costco or going through the managed care channel. So Pivot Hearing develops impactful, forward-thinking, real-world ideas, and we actually help execute on those ideas for the practices that we work with. We do that lightning fast and with total precision. So I've got up on the screen here all the services we offer kind of in 3 major categories, and Bob spoke to these a little bit in the fortification section, but helping practices acquire new patients, nurturing and reselling to your existing patients, and then of course, all the other practice management and coaching that we provide. So the KPI tool that Will shared there, My Vitals Pro, is brand new. And that's just one example of the types of tools that we provide and the consulting that we can do as a result. So, we believe that as fellow practice owners and seasoned consultants, nobody offers better thinking around how to handle things like the third-party issue today and as it changes, and how you can be successful both in the short term and in the long term. Nobody executes as quickly on the database decisions that we help you make with tools like My Vitals Pro. And so you can get things done quickly and move your business forward. The great thing about Pivot Hearing is that working with us often costs nothing. We have really competitive hearing aid pricing. You maintain manufacturer perks, benefits, warranties, all those sorts of things. So it's often a win-win. We'd love the chance to get to know you and your practice, talk about the third-party issue, dig into the data in your market, any of that sort of stuff. So I do invite you to visit our website, pivothearing.com, and schedule a one-on-one consultation if that interests you. Okay, so I know some people probably have to hop off, totally understand. We do have a handful of questions, so we'll go through as many of those as we can. And if you haven't asked your question yet and you'd like to, feel free. And if there are any questions that we don't get to or that you want to ask later, we can always handle those one-on-one. So one question here is from someone whose concern is around the third parties putting in language that we're not able to give patients, I think, difference in service, maybe relative to private pay patients, I think is the question. So Will, do you want to tackle that one?
Sure. So I think I can see it here. I want to make sure I understand the question here. Maybe you could reiterate that a little bit. I'm not sure.
So there's 2 different questions from the same person. So one is how the third parties are putting language in that we cannot give the patient the differences in service. And then the other question is, cannot sell the patient on our services.
Well, I know that some of the third-party contracts, they'll dictate the amount of services included when somebody purchases hearing aids through that channel or uses that benefit. We don't have much in the way of control over what that is. I've never heard of anything about the informing them of the differences between, going that direction versus some sort of a private pay access hearing type program. So I'm not aware of any of constraints around, just telling the patients the truth about what is available to them with their insurance, or if they choose to go another route, if that is in their best interest.
Okay, great. Here's another question. So this seems to be from someone who's saying that if a patient has benefits, that the onus or obligation is on the clinic, the provider, to find out what those benefits are and communicate those to the patient. Their concern is that if they do pay out of pocket for devices and find out afterwards that they had benefits, will they feel misled, lied to, hustled, et cetera? So do you want to speak to that, Will?
Sure. Yeah. No, I think checking patients' benefits and giving them all the information is a good idea. Absolutely. So I think that even if you're giving them that information, I think that sometimes the whatever third party benefit they have through their insurance is, it might be limited in terms of the options and the service that's included. And a patient might truly be better off going, even if it required a little bit more out of pocket expense, as long as they're aware of what the situation is, that they can deal directly and get that higher level of care and experience in a more private pay kind of model. So yeah, but no, I think informing them to the best of your ability, which is hard if you don't participate with some of the third parties. It's not always easy to get that information, but if you can get it, share it with the patient. And if you can't, obviously just encourage the patient to explore it on their own so that they're fully informed.
Almost an ethical kind of a thing to make sure that you explain things in detail about their program and your program, and I wouldn't see that as a big issue with the contracts that we all have to sign, because they're going to be interested in what happens with the program. They want to know what their program really covers, and then you can present your program, and they make the decision. You're not making any decisions at all for them. They're deciding, but they're making an informed decision, which is the big difference, I think.
Hey, Will, is it
Agreed.
fair to
Yeah.
say too that, yeah, I mean, as you're presenting what their insurance covers, and if you've been able to move to that divestment world where you don't work with them, you can say, yeah, it looks like you have a benefit. Either I was able to figure out what it is or I wasn't because I'm not a provider. And then, I mean, at that point, you're able to say, right, and I don't work with that plan. So, you know, you're going to have to go somewhere else. And this person's already made the appointment. They've gotten the ride to your office. They've sat there. They've filled out all your paperwork. You've done the hearing or whatever, right? And so, and then you have this compelling alternative with something like the Access Hearing Program. So it seems like that's a situation too, where yes, having divested from some or all of the plans really makes that conversation powerful, and you're not probably super likely to lose that patient if you have a compelling alternative like the Access Program. Is that right?
Yeah, absolutely. I completely agree with that. So.
Okay, great. So here's a question around what's happening with California's investigation into anti-kickback statute violations by TPAs. To be honest, I don't have like I don't know a ton about it. I do know what you're referencing. So for those of you who aren't aware, my understanding is that there are some professional organizations that are looking into whether third parties actually violate anti-kickback statutes, in that they receive, money in exchange for referring a patient. That's about the extent of my knowledge of it. I would say, I think it's very interesting. I don't know much about it. I don't know where it's going to go. Obviously, that would be amazing. And we would certainly support anything like that. And I think that it harkens back a little bit to what Bob was talking about around, banding together and legislative changes and things like that. We certainly support efforts like that. Whether or not focusing on it or being a part of it is a great use of any individual practice owner's time would have to be an individual decision. But if something like that were to transpire and the TPAs were not allowed to act in the manner that they are now, that would be a game changer. I don't know, Bob, Will, do you have anything else to add on that?
No, yeah, if it, we completely support anything along those lines, if it's good for patients and good for private practice. But, there's a lot of institutional type of resources and capital that's gone into this whole managed care kind of industrial complex. So the legal strategies are it's just difficult for those of us in a private practice context to affect much change there. And you'd think that people with spending, hundreds of millions of dollars in some of these cases with high powered attorneys and obvious political connections, I would just be somewhat skeptical of I'd be pleasantly surprised if any of these legal efforts were to be successful, but we need to proceed under the assumption that, we probably won't be successful in that regard. And if it comes, great.
Yeah, perfect. Okay, here's a question about Abrams hearing tracker industry chart and where Pivot Hearing falls. I'm actually proud to say we're not on there. We are a family-owned company. So Will and I are actually brother and sister, and our family's been in the industry for 5 generations, and we have a private practice of our own with 7 locations in the Bay Area, and then we have Pivot Hearing as well, with staff of audiologists, hearing instrument specialists, and business people who run both organizations, and family owned and independent, and love working with other independent practice owners. So that's kind of the tie-in. Okay, another question here. I don't know the answer to this, so hopefully one of you will. Is it legal to offer a private pay discount? Do you guys know the answer to that?
I think it probably depends on the context. I don't know, Bob, do you have a?
Well, I don't know whether it's even a good idea to offer a private pay discount. It may or may not be something that's even a good business decision to do. However, if you choose if you have, I think you'd probably have to do it with a category. If you've been my patient for in the past, or some sort of a category, so that if anybody knocked on your door and said, hey, you shouldn't do that because we're going to sue you, the idea would be that Well, I do this for all patients that are in this category. And that way, then it's not discriminatory against one versus another and all those things. So that'd be how I would do it, I think.
Yeah, and I would say all 50 states have their own insurance commissioner.
Yeah.
So insurance is a state by state issue. So depending on it might be legal in one state to do one thing and not in another. So, you'd want to get some sort of counsel who's familiar with the laws and regulatory situation in your market.
Yeah, that's a great idea. Talk with your attorney about that, and they can help you set up that program if indeed you choose to do it.
Okay, great. Here's a question about the My Vitals Pro software that Will showed. The question is around whether there's a fee to utilize that software or whether it's complimentary. I will say for Pivot Hearing members, that software is complimentary. And if anybody's interested in discussing whether they might be able to use that software in their practice, whether you're already a Pivot Hearing member or if you're not, I would suggest just to contact us. Again, phone number, website, email, any of that, info@pivothearing.com works too. And we can set up a one-on-one call and talk to you about your needs and which practice management software you use and how it works and all that. So, okay, I have, let's see, here's a question from someone saying it's easier to steer patients to a plan like the Access Hearing program if they don't have an actual benefit, but just a discount plan. When they have an actual benefit, for example, something like $1,000 per ear, it seems it's going to be very difficult to steer them in that direction. It seems like more Advantage plans are including actual benefits. Do you find that to be true?
Yes, particularly in some regions of the country, more so than others, for whatever reason. And yeah, I mean, there's places where certain Medicare Advantage plans where patients can get hearing aids for, I think I've heard $99 each. So there are some of these plans that, like, no matter how, even if you gave your hearing aids away, you'd be tough to compete with. So thankfully, that's not the case for all or even the majority. So yeah, and then I guess at that point, if you can't compete with it with some sort of an access program, you just need to look at whether or not participating with that particular managed care plan or managed care in general makes sense, given the fact that there isn't a great, either you take it and you accept the fitting fee or you don't, and you look at the business impacts of both and you try to make the decision that makes the most sense for your practice.
And I would add just that that it isn't just the product. There's all these kinds of things that all of us do every single day to follow this person or to interact with them and their families and all these different things that go along that are not necessarily part of these Medicare Advantage programs. So it's a lot more than just the product itself. Now, the patient comes in, they think it's just the product, but once we explain to them exactly that it's more than that, then it's a different interaction.
Great. Okay, so there's a couple questions here that I'm kind of going to lump together and probably have you take, Will, or Bob, either one. So one question is whether individual providers across the country could join together and form their own managed care group to compete with other managed cares, with higher payouts to providers. So that's kind of one idea. And then someone else, again, different, but same kind of category, where saying, could, we cooperatively as groups of providers challenge the legal conduct of these TPAs to consider patients as the injured party rather than the providers. So I think just some questions around like competing with the managed care entities on a large scale, and then also possible like legal regulatory action. Do you want to take those, Will?
So I guess like my answer to that would be maybe it's possible on both fronts, but you got to keep in mind that your adversary in this would be, organizations like United Healthcare, which is the largest health insurance company in the world, who has obviously infinite in comparison more resources legally, financially than even if all hearing care professionals banded together, they'd still just blow us out of the water in terms of ability to fight a battle like that. So maybe I think our perspective from an individual private practice perspective is that the best use of your time and resources and energy? When we kind of think that you can, on a one-by-one, patient-by-patient experience or interaction, you can kind of compete there, where we actually have some advantages, which is in the clinic, providing that exceptional care. That's one thing that United Healthcare can't do, is provide the kind of care and service and experience to individual patients. So,
And I'll just add
yeah.
something I've heard Will say before that I think fits in really well there, which is that like at that level, that individual patient in clinic fitting level, they need you more than you need them, right? So you actually have a real advantage there. Whereas in any kind of like legislative lawsuit type matter, you're like Bob said earlier, just the absolute ultimate underdog, right? So yeah. Okay. This question, there's a bunch of detail around a specific patient experience, but I think the overall question is, can the TPAs require providers to provide non-covered services for free just because we're in network with them, even if the patient isn't purchasing hearing aids through them? So I'm guessing the answer here is like, you just would probably have to go back and review the contract in detail and then decide if you want to participate. Is that what you would say too, Will?
Yeah, I would want to review the contract and then see what was required. And perhaps there's some language in there. I've seen some kind of surprising things in these contracts. So that doesn't sound like something that anybody would agree to, but yeah, I just have to see the contract.
As much as we all don't like the legal system, but for one reason or another, and I found that as the practice moved on over the years, I had to do more consulting with attorneys and accountants and people like that than I ever did before, just simply because there's more legal ease in virtually all the contracts that these managed care companies and others have. So you really need to have a good relationship with an attorney that can help you through some of those things. And of course, the other thing that helps a lot, and I mean, it really helps a lot to have somebody who cares about you and your practice, and somebody who cares about you and your practice. That's not a big, huge conglomerate. That's the people that you know, and you can call up and say, "Hey, what do you think about this?" And then they can say, "Well, in your state, we have to be very careful about that because we've seen XYZ over here." And so my suggestion is first talk with people like Will and Chelsea and those guys first. Then maybe if they have some concerns, because they see people from everywhere, and then go to the attorney if they have some concerns and go from there. So those things could be in there, or they may not even be in there. So I guess that would be my response.
Yeah, absolutely. We'd be happy to do that. Here's a question around differentiating service levels between TPA patients and private pay patients, just about it being maybe logistically difficult and possibly not even ethical. Do either of you have a take on that?
I can take a quick stab at that. I mean, I think reasonable minds can disagree on these types of matters, but I think a managed care hearing aid purchase is generally going to be something resembling an unbundled hearing aid purchase, where you might get some service at the outset, maybe it's a year, something like that. But eventually it's a little bit more of a pay-as-you-go model. So one relatively easy, or at least kind of logical way to compete from a private practice perspective would be to go with more of a bundled approach, even if that means there's a little bit more spend for the patient when they're obtaining their hearing aids. And I think you can make a compelling case for why that may be in the patient's best interest. We don't know exactly what your needs are going to be. We want to make sure that you're going to be able to come in and see us as much as possible for keep you hearing as best as possible from here on out. So I like to lean into the more bundled professional services model, as opposed to trying to compete with the third party by unbundling. And then it's really more of a side by side, more of an apples to apples comparison, where if you're offering a more bundled approach, it's not really an apples to apples comparison. And we think that you could make a compelling case to a patient. So,
but there will be some places where you can't do that bundled thing, Will. And if not, then guess what? Then you're with that TPA patient, and you're going to be trying to hustle them over to the period of time with your fabulous clinical capability, and then at the end, then possibly you can sell them an unbundled program of some kind, maybe a 2-year program or a 1-year program or something of that nature.
Yeah, absolutely. With unbundling, I generally think the service packages is the way to go, so that a patient has access to you and your professional services as needed, because these, we all know busy hearing care practices have lots and lots of appointments every day, keeping people's hearing aids working properly and doing kind of routine service that's critical to their overall hearing health. So.
Okay, great. I think we've answered all the questions that came in. If I missed any, I apologize. But again, we're easy to get a hold of, pivothearing.com. So if I didn't answer your question or you have any questions as you think about this in the future, don't hesitate to reach out. I really appreciate everyone taking time out of what I know was probably a very busy day in the middle of the week. So thank you again. And we look forward to connecting with you soon. Have a great rest of your day. Take care.
Thanks, everybody.